I think from 1st of July onwards, all of you who are going for any assessments to the hospitals are going to be assessing the hospitals against the 4th edition. We have also requested NABH that we quickly run through the full 10 chapters changes. The main changes, as you all know, would be in the first 5 chapters and a little more in CQI, but the last 4 chapters do not have very significant changes. So we will be concentrating mainly on AAC, COP, few changes in HIC, few in CQI, PRE has some additional elements, MOM, just a few additions. Revisiting the hospital standards, we have 10 chapters. We now have 105 standards in the 4th edition, and we have 683 objective elements. This is the quick breakup. All of us are quite familiar, but just revisit. And these are for the management-centered standards, totaling to 105 and 683. Coming back to AAC 1, I'm going to be hitting not on all the standards, only the standards where either there is a new objective element or there is a new interpretation that has been added. So in AAC 1B, this is a new objective element which says each defined service should have appropriate diagnostic and treatment facilities with suitably qualified personnel who are present in the outpatient, inpatient, and emergency cover. Interpretation is that obviously when an organization will ensure before starting a service that suitably qualified staff are available for the patient care needs, and this should be available in OPD as well as IPD, and there should be coverage by a consultant for emergency cover. The infrastructure as well as treatment and diagnostic facilities should be available for regular functioning. Now this objective element is not easy, it's quite a wide objective element to go and assess. So I would say, how do we start? While the 3rd edition addressed whether the scope is defined or not, in the 4th edition, through this objective element, we go a step further to make sure that the HCO, whatever they have written in the scope, they ensure that the available infrastructure and staff is present, and the services are comprehensive for the patient care needs. So usually you will agree with me as a guidance that while in bigger hospitals, suppose you are providing neurosurgery in a tertiary care hospital, usually the complement of all the equipment, infrastructure, ICUs, beds, everything is available. In smaller hospitals, sometimes this becomes a challenge, where they write, say, neurosurgery in their scope, but in a 50-bedded or a 70-bedded hospital, when you go in and assess, you may not find everything available comprehensively. That's where you're going to find a little bit of a challenge. For example, suppose let's take a 50-bedded hospital has defined neurosurgery in its scope of assessment, but when you go there as an assessor, you find that there's only one visiting neurosurgeon who does an OPD twice a week, and he attends patients with head injury and other neurological problems. The hospital has an 8-bedded ICU, and with nurses who are not specialty trained in managing neurosurgery cases. In that ICU, there is one MBBS doctor on night duty and an anesthetist is on call. The OT is not open round the clock, neither is there a round the clock on-call consultant cover. The hospital does not have CT facility, and there is no cover for the OPD if the consultant goes on leave. Now this example highlights the gaps in the provision of care related to the defined scope. So how should an HCU address this gap? The HCU should identify the patient needs and based on it should be able to modify its scope. Either it will not include neurosurgery in its defined scope and not offer such services, or if they do have to offer, they should mention the limit that they are only having OPD, and then they will screen an onward transfer for any emergency or admission. Or the third option is obviously they'll get an NC against this and they will have to enhance their facilities to ensure that comprehensive cover is available round the clock. How would you go and assess a hospital to begin with on this? The assessment checkpoint could be that you obtain a list of the defined scope of services through their application, ask for, maybe pick up 2 departments or 3 departments and check what are the equipments available for that specialty. Check if they have OTs, beds, ICUs related to that. do a random dipstick sampling on what is the consultant cover, what are the cross referrals, how many doctors are available, how ER services are provided, check the on-call system, check the OPD system, and what kind of volumes and patients they are treating, along with what manuals they have or quality assurance program they have for that specialty. So you can get in their processes, you can get a sample of 2-3 patients in the defined scope as a dipstick sample, and do a clinical tracer from admission to discharge to see whether the patient is actually getting all the care. You should, as assessors, try and familiarize yourself with the structural requirements of staff, equipment, infrastructure related to various departments to increase our own background knowledge so that we can have a deeper understanding of the patient care needs in those specialities. The next AAC 1C is the defined healthcare services are prominently displayed. In the interpretation, NABH now says that healthcare services routinely associated with the standard of care within the defined scope of healthcare services. Please note this is very important, but not offered in the organization should be clearly displayed as not available. So, for instance, if for instance a hospital is defining that they have oncology as their service, as their scope of services, within oncology they do not have radiation therapy, right? So healthcare services routinely associated with the standard of care within the defined scope. So if they don't have radiation therapy, they should be writing in their scope oncology. Under that they can put surgical oncology, medical oncology, but for radiation oncology they should then specify that radiation oncology is not available. And to make it a little more patient friendly, they can also write referral services available. They can have a tie-up or they can have a referral arrangement with another hospital so that the patient doesn't feel that, oh, this is a half-hearted attempt to take care of cancer. Next slide is, we have already covered. We come to AAC 2. The organization has a well-defined registration and admission process. Here they have added in the interpretation, additional documentation as required shall be included for foreign nationals. As we know that there is a special form, C form for FRRO, which is an online form. You can download it, get it filled with patients, signed, and the hospital has to submit it to FRRO within a stipulated time. So what will you check? You'll obviously ask for a sample of foreign national admissions. Ask them, do you get foreign nationals in your hospital? Ask them a sample of foreign nationals and validate that this C form has been filled and submitted in those cases as a dipstick audit. The next F objective element is relating to that the hospital prioritizes the access to healthcare services according to the clinical needs of the patient. Now here we all know that in the emergency department the triaging is already in place. So triaging is a way of prioritizing the clinical needs of a patient in the emergency. But here the objective element goes beyond ER and says that even in OPD or IPD, if there is a waiting, then you should prioritize which patient should get attention first. Now this is a new objective element, so obviously there are various methods by which we can go and assess whether the hospital is sensitive to the needs, clinical needs of the patients in IPD and in OPD. So from an implementation perspective, HCOs can take up various formal and informal methods to monitor, assess and prioritize the patient's needs, including for diagnostic. Second, some hospitals have been using a visual triage system to quickly assess the patients, how they are looking, do they have a physical disability, and they can, just subjectively help them and bring them in first. We already are saying for vulnerable patients or a patient having high fever or a patient whose, blood pressure is low, should be seen out of turn and maybe referred to the emergency department. The third situation could be that the patient himself or herself may reach out to the staff and say, I'm not feeling well, please give me a priority. So the patient can either be sent to the ER or seen in the OPD as the situation demands. In some of the fortunate hospitals where HCOs have the facility for nurses screening the OPD patients, you can have a formal system. The World Health Organization has some examples of ABCDE triad system, which is a visual and triad system which can be used to prioritize clinical needs. So there are various examples. We don't expect you to have a documented system to go and check patients, check the policy or go and check this. You should just have when you go to assess, just ask the staff to, in the OPD, go and interview the staff on, ask them an indirect question or a direct question that, suppose a patient is unwell, what would you do? How would you prioritize? And, based on the response of that, you should give an NC or not a NC. We are also saying that in the first 6 months, we should not be very imposing on the HCO about being very strict about imposing the new standards. We know that it's a new area and the hospitals will take their time to implement. So if the intent is, they've started having an approach towards those problems of the new standards, and they have started implementing some processes, we should be very encouraging to them. AAC 3 standard, there's an appropriate mechanism for transfer in or transfer out. Here, the NABH has simplified. We have found many, comments in NC reports where our assessors say that the doctors or nurses have not undergone a AHA certified ACLS program. And they were maybe rightly in interpreting ACLS word, whereas I don't think NABH has ever insisted on AHA. Now, to make it easier, NABH has removed the word ACLS everywhere in the standard and have said, suitably trained persons. So we request all of you to look at the processes of readiness, but do not, insist on a AHA certified program. If they have it, it's a compliment to the hospital. If they don't have it, check whether their processes and their staff are able to meet the requirements of the patients with an internal certification or however they want to, define the competence. Please accept it if they are able to meet the intent and the training needs are met, even with or without AHA. AAC 3B, where they are talking about, the emergency and transfer out of and referral of unstable patients. So here again they are saying that they are just specifying in the interpretation, patients needing transfer include those who have come to the emergency but need to be transferred to another organization, and those who are already admitted but now require care in another organization. So both, okay? And there should be a policy and a procedure to be able to guide this. I hope it's quite self-explanatory. This is again the same. Sorry, there is a repeat. Again in AAC 3D, staff required for transfer or referral, basic or advanced CPR is replacing BLS or ACLS. So again, it's not that you need a AHA certified course, but they can have any kind of basic or advanced CPR training which should meet the needs of the patient. Organization gives a summary of patient's condition and the treatment given. Here there is an additional requirement in the interpretation saying a copy of the same shall be retained. So whatever you are giving out to the patient at the time of transfer, we are bound to keep a copy in our records. AAC 4 is around initial assessment. The organization defines and documents the content of the initial assessment for OP, IP and emergency patients. They have just added a small sentence in the interpretation saying abridged documentation may be used for daycare. So if it's a patient of daycare, you don't need to have a lengthy, elaborate initial assessment format. It can be shorter. So I think NABH is also being very practical in their expectations. and realistic. AAC 4 is about initial assessment for nutritional screening for nutritional needs. Now here I'd like to add that why nutritional screening has come in as an important area in a hospital. Many research studies have proven that 10 to 20% of patients who visit a hospital for any reason, whether it's eye surgery or just a dental problem, could be for any problem, they are generally having nutritional deficiency. And so when they come into the hospital, it's a good opportunity to detect and treat holistically, other than for the primary reason. This is one reason why nutritional screening has been introduced. The second reason is research has proven that any patient, even with an acute illness, if nutritionally deficient, their clinical outcomes are going to be far poorer than those who are in a proper nutritional state. So it becomes important for us that other than looking at the primary causes for which the patient is coming to us and assessing them, we must also look at their nutritional status and then do interventions as necessary if they find that there is a need. Okay, so the intent is to be understood in this way. We all know that we are not used to doing this in busy OPDs, in busy IPDs, and we tend to focus only on the primary reason for which the patient is coming. But gradually we should encourage the hospitals to take up some small ways of screening the patients to identify nutritional deficiencies. So here the interpretation says that it should be done for all patients including OP and IP, and if you find that the screening is showing a deficiency, then you send the patient for a detailed nutritional assessment wherever it is applicable. So I have already explained this slide on the guidance that many of 10 to 40% in fact patients are malnourished when they come to hospitals. Some say 20%. So early detection is a great benefit for improving clinical outcomes in these patients. So how do you identify, how do you organize a hospital for nutritional screening? Obviously, the hospital should have a policy in place and a procedure for doing this. We should be flexible as assessors to leave it on the hospitals. Again, we are saying you have an approach, you have an intent in place, and then you go into deployment, and then you look at results. So in the beginning, if a new hospital has an approach, it is just going for accreditation for the first time, they have met their intent, they've started screening patients, maybe they're not analyzing whether something great has happened to the patient or not, whether they've done it 100% correct. We should be practical and encourage them and say, yes, they are on the right track. They've begun their journey for screening the patients in OPD and IPD. Maybe it's just BI, maybe it's just weight. Maybe other hospitals will have very elaborate systems. Some will have elementary systems. We must go along with all of them. So long as, and we know that every hospital is going to have different levels of maturity and achievement. But over the years, their systems should become, processes should become mature, and they should be able to even assess how they are doing their programs and try and improve them. Okay, so that's the phase that plan, do, check, act, or approach, deploy, analyze, improve, various ways. Even as assessors, we have to go along with the hospitals in their journey of starting accreditation and onward improvement. This applies to every standard. And I hope all of us are going to use that maturity and look at a hospital as though it was our own hospital who was doing things, and be very mature in what we expect from them. So I've just given some examples. This PPT will be available for you. There are many examples available on the internet on nutritional screening tools, which if you want to take as a guidance for your own hospitals, or if some hospital wants you can just subjectively, without imposing, offer them some guidance. Okay? When you go to assess, please review the policy of the hospitals and look for random samples of nutritional screening in OPD and IPD, and interview some staff in the OPD and IPD. The AAC 4G is about the initial assessment results in documented care plan. Here, NABH has tried to simplify what do you mean by documented care plan, because we've had a lot of confusion most of our doctors and nurses, maybe nurses are, but doctors are not taught to document care plans or even understand what is the meaning of a care plan when they go through their studies and also in practice. So this is a new understanding, and there was a lot of confusion over when the third edition was released. So here NABH has clarified that if in the record you find a provisional oblique DD, a differential diagnosis, you have some investigations advised, you have an initial treatment suggested or specific instructions, we should accept this as a care plan. Okay? So that's the condition that has been brought about. AAC 4J, the plan of care reflects the desired results of treatment, care or service. Now here, the interpretation is the components of the care plan are directed to achieve desired outcomes which are apparent to the treating team members and the patient family. This is not about clinical outcomes, please. So plan of care or care plan is that you should encourage your doctors and nurses to start writing things like what are the outcomes which is apparent to the patient and the family. So for instance, I can give an example of say pain. So if your care plan includes patients who are having severe pain and you want to reduce the pain, you can specify what pain relief as a part of the care plan, which is going to be, which the patient also understands, right? Or if you're going to increase the mobility, or you're going to reduce the breathlessness. So some things which the family can understand as a desired outcome of the treatment can be documented. So that should start getting encouraged. But we have removed the words called goals. Okay. Here also it's an open-ended objective element. There is no black and white solution. You have to read on the internet best practices, understand how various hospitals have done it, learn ourselves, and then give expectations to the hospitals. And therefore, when you go and assess, please do not be very strict. Okay. So again, the guidance is about it's about taking the patients into a partnership approach and giving them personalized instruction and feedback about management of their condition. It's about telling them things that they will know and understand. Those parts can be included in the care plan. In terms of structure of care planning, there are some examples which have been picked from best practices, which are on nursing diagnosis, which are just added over here for your benefit, only as a reference, not as a rule. AAC 5 about reassessment of patients. Very simple interpretation has been added, saying the changing care plan has to be documented. Okay, and therefore, if there is a change in the care plan, you don't just change the treatment, but also in the document of the medical record, the doctor should write that, what are the new instructions that have been given. Self-explanatory. AAC 5 is a new objective element on the rapid response teams. And here I will read it out. The organization lays down guidelines and implements processes to identify early warning signs of change or deterioration in the clinical condition for initiating prompt interventions. The organization trains the staff to against defined physiological parameters to identify clinical deterioration. And these may include assessment of vital parameters, airway circulation, neurological status, vitals, or other concerns which may be felt by the staff or the patient or patient's family. And there should be a mechanism by which an alert is, sounded and an appropriate medical attention is given to the patient. We all commonly may call this MUSE or rapid response teams. The logic behind this is that, evidence has been shown that before a patient crashes into a cardiac arrest, there is about 8 hours or 10 hours before that, there are some changes happening in the patient. And if we were to be sensitive and detect these changes in time and give medical interventions in time, then we are reducing the morbidity and mortality of patients, or making sure that they don't go into a cardiac arrest. Organizations that have successfully implemented these rapid response teams have been shown to reduce their mortality rates by 10 to 20% and reduce their clinical outcome complications of patients also. So this is proven. So NABH is requiring that all hospitals should have a rapid response team or a medical alert team, however you may call it, where the nurse knows what to look out for other than her routine measures and routine monitoring. And if she finds, you have a cutoff that, okay, if the blood pressure of a patient is going down in the ward from 70 to 40, immediately alert a team, and that team's response should also be standardized in the organization. That means it should be timely, say within 5 minutes. They come in, they assess the patient, and they give the intervention of saying, okay, shift the patient to the ICU or whatever, alter the treatment, call a consultant. So those are the two things that are required to be put into place. The nurses need to be able to detect early warning signs. What these early warning signs are should be defined in the hospital. And the second thing is there should be a team which comes in a timely manner who assesses the patient and guides appropriately. So I've just given a little guidance on this through these slides. And what will you check? You will review the policy for the early warning signs in the hospital. You may ask them to show you samples of records of incidents, and you may interview staff, nurses and doctors on what the system is and how it works. AAC 6 is around 6, 7 and 8 are covering the laboratory services. Here a new objective element, modified objective element specifies that the lab should have adequate space, electrical and plumbing requirements and equipment. In terms of, and there should be appropriate workflow, and reports should not be delayed due to lack of equipment or manpower. Now we all know that there are no laid down standards by NABH on what is an ideal space for a lab given the workload or the ideal staffing. So again, there is a lot of subjectivity that has to be exercised here. Please look at it with the perspective of, when you walk in, you visually see, is there clutter in the lab? Is there a chance of sample mixing? Is there a chance of staff getting injured due to, overcrowding? Is there a, issue of overload of equipment given the electricity load? Look at it in a subjective manner. And if you find that, it does look cluttered, then you can put that down as an observation. But there's no norm that you can follow. Same way, there is a new objective element on the manpower. There's no standard which is defined as of today. There may be a few references here and there, but again, we have to use our own judgment to find out whether there's enough staff to work for during the shift or during the emergencies, etc. in the lab. Okay. Critical results, AAC 6G, the interpretation is now extending to that critical results that are found on outsourced investigation should also be informed immediately to the hospital and to the patient's caregivers. Okay. AAC 6H is that, again, a small interpretation in red is changed, that if the organization is giving a test to an outsourced lab, then the result should be coming on the outsourced lab's letterhead. If not, if you're giving it on your own letterhead, then you must give a reference that to bring in transparency, that the source, date and reference number of the report given by the outsourced lab should be mentioned in that report, so that the patient knows and there is a spirit of transparency that the report was actually given to an outsourced lab. AAC 6I, there's a mechanism to recall or amend reports wherever applicable. So the recall process is a new objective element. So if there's an error which has been detected at any stage, then the organization should be able to recall the report, correct it, and do CAPA as appropriate. AAC 7 is about the QA program. We are familiar. Here they have added that the lab should also obtain feedback from various stakeholders to evaluate the lab services. So obviously, maybe the patient's feedback can be taken, maybe the referring doctor's feedback can be taken, nurses who send samples to the lab. Time to time, the lab should be taking feedback from the stakeholders to identify whether they are satisfied with the quality of the reports, the quality of the lab services, the service that they are providing. AAC 7 is about surveillance of test results, where they have just specified controls, external, internal QA results, non-conformances. AAC 7 is covering periodic calibration and maintenance, where now they want that point of care equipment should also be calibrated. So obviously when we go as assessors, we should ask them this question, that do you have a calibration system for point of care equipment also. AAC 8 is around lab safety, and here they have specified in the interpretation that the training needs identification has to be done for the staff appropriately. AAC 8E is around that, now they have made it in the interpretation that all lab staff should be appropriately immunized. We all know AAC 9, 10, 11 are around the imaging services, very much the same that was there in the lab. The same standards and a few additional standards have been added in imaging. So the space, infrastructure, equipment, manpower, reporting, workflows should be looked at when we go as assessors. Again, don't be judgmental. Look at it given the workload, given the scope of the service, and pass your own comments on if you feel there is clutter or there's overflow, there's too much work on the staff, you can put in an NC. Otherwise, not. Space is always a problem in hospitals, especially for support functions. So do look at efficiencies and how they are managing rather than insisting on a big space. Look at the intent being met. But some hospitals push their labs or imaging into such corners that it becomes very dangerous and ineffective. Those are the kind of few outliers that we expect to be highlighted. Not that every lab or every imaging center is given an NC on adequate space. We must understand space always comes at a big premium. So AAC 9F is around, interpretation. Imaging results are available within a defined time frame. Here, NABH wants us to be a little more explicit on saying that the organization will monitor the waiting times taken to do a test, and time taken to do the test, time taken for the reports, and this should cover all IPD, OPD, and emergency patients. Not all modalities. You can do a sample, and the hospital should start getting sensitive to how long patients are being made to wait and have an approach towards addressing this. Critical results, AAC 9G, it's about critical results. The same way as for lab, here we want that the critical results of outsourced investigation should also be reported in an immediate manner and actions to be taken. Results AAC 9H, results are reported in a standardized manner. So here we have given some specifications on what should be the format of a result. So there should be an ID, the demographics, who is reporting the result, the name of the doctor who's reporting, and few issues on the outsourced imaging. So obviously when we go to assess, we can just map, look at sample reports and see whether these requirements that are specified in NABH have been met. Very easy to assess. Similar to the lab, AAC 9 is talking about the recall mechanism. So if there's an error which has happened, then we must have a mechanism to recall it and a CAPA. So you can just find out, go to the lab or go to the imaging center, and when you're doing the assessment, ask them that have you had any, where's your recall policy? Have you had any incident of recalling for errors? Are errors reported firstly as an incident? And what is your method for recalling these erroneous reports, and how do you look at the CAPA? So in the beginning, if they have an approach, they have a policy, people are sensitized to being able to recall their reports, even if they don't have a very good robust CAPA action. In the next 6 months, please do not be very strict, because we must give the hospitals time to settle in with the new standards. AAC 10 is about QA program, and here they are saying that the QA program should involve all stakeholders and it should be comprehensive, looking at all aspects of QA, equipment, protocols, safety, education and surveillance, and of course meeting the regulatory requirements of AERB. More objective element regarding test results. The program addresses periodic internal and external peer review of imaging protocols and results using appropriate sampling. So now they want a peer review system. We all know what a peer is. A peer is a person with equal qualifications and experience as the person who is being reviewed. So it's not that, I'm not a radiologist and I go and do a evaluation of a test result. That's not a peer review. Peer review is a like to like, specialist to specialist. So the hospital needs to have a peer review system in place to review the outcomes of interventional procedures in a structured manner. They can have a sample size. So it's like an audit, okay, or a discrepancy meeting. So you can go and ask them for records and ask them what they are doing. Look at how the process is working in the hospital, and if any CAPA has been initiated based on the findings. But let every hospital do it the way that they would like to do. A system is in place to ensure appropriateness of investigations and procedures for the clinical indication. Here, we want that, with the rational investigations to be ordered by doctors. We are suggesting that anybody in the radiology department should be able to screen whatever is the investigation requests are coming in. And if on an exceptional case they find that a wrong test has been ordered, they should be able to reach out to the referring doctor and suggest a change. Right? So screening means that you take proactive action. We don't expect the radiology department to change its entire infrastructure and staff and have a full-time radiologist round the clock, and every investigation request is screened by a radiologist and then okayed, and then you let the patient come in. No, we don't want that. The intent is to sensitize the referring doctors from time to time, and these should be exceptions rather than the rule, to say that, okay, this test you have advised, but we suggest that some other test will be more appropriate for this kind of a condition. Of course, it is important that the referring doctors must write the requirements for the test in a proper manner. So the investigation, what you should stress on in the assessment is that the hospitals have started improving their process of documenting a test order. So, rather than writing on an OPD prescription CT scan of the head, we should encourage the hospitals to have a reporting form, a request form, in which they write the clinical reason or the short clinical findings and why the doctor is wanting a CT scan to rule out this or to diagnose this, which will help the radiology team also understand and interpret what this patient has come for. Again, I'm saying don't be strict. See if the hospital has an approach for this. They've started their journey of intervening in this area. We should be encouraging the hospitals as they go on. Maybe in the next year, in 2017, when we go back to assess, we will become more firm and expect their process to be embedded in a more mature manner and become work as usual for the hospital. But in the next 6 months, just look at approach and intent. Okay? So requisition slips you should be looking at and asking whether the staff of the radiology department are aware of that this is a need in the hospital. Then we come to AAC 10F, where they have just specified against the documentation of CAPA, and it's just stressing that the HCO shall institute CAPA as appropriate. AAC 11 is around safety of the imaging services. We know, just like 6, 7, 8 was for lab, 9, 10, 11, the radiation safety aspects of radiology have been stressed. Here in the interpretation, they have added on the ALARA implementation, as low as reasonably achievable. Here your radiology department should be making policies on ALARA. This may be a new requirement. And while they may be doing this in practice, but they can have an ALARA policy and an education, and also start feeding it back to all the radiologists in the system. So how much dosage has to be given for what condition, and according to the weight of the patient. We are not radiology experts, but we can ask them how they have approached this problem. Do they have a policy? Give them a chance and say, you tell us how you are following the ALARA principle in your department. So if they convince you that yes, they are very concerned about radiation exposure to patients and they are monitoring it and looking after it, we should be encouraging and satisfied. WHO has given some very good guidelines on this. If we want to learn for our own knowledge, you can go to the WHO site and look at this. I've given a hyperlink for this also in this slide presentation. Hospital may publish its own policy on ALARA, which will also be a commendable thing to do. So check the hospital's policy when we go to assess, and ask them about few precautions that they are being used for meeting this requirement. Patients are AAC 11. This is a new objective element regarding screening of patients for safety and risk. So there are two areas where NABH specifically has brought in. One is that childbearing age group patients must be screened for pregnancy through a questionnaire or an interview, and patients undergoing MRI should be screened for any magnetic substance. They are also extending this to attendants who are accompanying the patient into the imaging area. And informed consent, the third thing that they've asked is that make sure informed consent is in place wherever high-risk procedures are being done in the imaging department. So that's what we will check when we go for assessment. So check the informed consents in the radiology department, check the screening questionnaire for MRI and for pregnancy screening for childbearing women in radiology. Do these three things when you go to the radiology department and you have met the requirements. AAC 11E is about shielding of body parts of staff and patient and attendants whenever there is a exposure. Okay, so we are already doing this in our assessments. It's just that we are making sure that we are checking this properly now. It's just being stressed upon. AAC 11G is about training of imaging and ancillary personnel in image safety and radiation safety. So here the stress is on that imaging safety practices are including training of ancillary people also. So if there's a GDA or an attendant, he or she also needs to know that what all safety norms have to be followed when they are in the MRI area. Kinking of tubes, prevention and handling patients in the imaging area. So radiation safety has to go beyond just the patient and the immediate radiation workers. It has to go to the ancillary staff and families of patients also. The next slide is on AAC 12, which is on multidisciplinary care. We now have 3 more objective elements to cover in this chapter. Multidisciplinary care, again, I do understand, and I'm sure all of you agree, that this is a very subjective and a vague, iffy kind of a standard. But now what NABH has done is that certain key points are important which have to be checked. So they have brought in about structured clinical handover by doctors and nurses. So we must have a proper handover system between doctor to doctor and nurse to nurse during shift change, or when the patient is transferred from one department to another. I'm not saying doctor to doctor handover from one department to another. Appropriate handover has to happen. So if a patient is going from one ICU to the radiology department or from emergency to ICU, there should be a document which details the clinical summary of the patient in a very short form. It can be a 1-pager, it can be a half a pager, and somebody hands over this and somebody at the other end receives this. It need not be doctor and nurse, it could be doctor or nurse, it could be only nurse, but shift handovers should be done between doctor to doctor as well as nurse to nurse, and there should be a record of this. So we expect that when we go for assessment, we will check this at sample key areas and give it. I'd like to reiterate over here, NABH has at the assessor conclave also said that suppose you are doing 10 samples of one objective element, which you may not. You may only do 3 given the time frame. I'm just giving a number 10 because it's easy to interpret. If you find 7 out of 10 samples are meeting the requirement, they will get a 10 score. 70% and above, you will give them a met expectation, met the requirement. If the requirements are between 7 and 3, then you will give them a partially met. That means a 5. If it is 3 out of 10 they have met, then we will give them a 0. So these are the thumb rules that we expect you to follow when you do an assessment. We do expect you to do repeat samples as many as possible. The samples can be repeated between assessors and then we can collate our results, but try and get as wide a sampling as possible given the constraints and the depth of assessment that we have to cover. And of course, it also depends on, like, if you want to see handovers, handovers are happening at multiple points. So if you take a larger sample, it would be more appropriate. Whereas a code blue may not happen that often. So you can do 2 examples or 3 examples. But handover should be checked at many places. AAC 12 is around continuity of care. Here again, the handover process is also around continuity of care, but the stress in this part is that whenever there is a change in the schedule, the organization has defined timelines for waiting, and to ensure continuity, patients are informed whenever there is a deviation from the timeline. I know this is not very practical to do. It is not easy for an HCO to do this. So I would say wherever it is critical, or if the organization has taken an approach to start explaining to the patients about waiting, then we should accept it. We should encourage them to be more accountable to the patients in terms of managing their schedules. So for instance, you can go and do a sample and find out about OT schedules. Okay, patient was scheduled to go at 8, but their patient is waiting until 12 o'clock and the patient has not been wheeled in. Now you have to check with the patient and the family. Has somebody informed you that your surgery is being delayed? If the patient says yes, we will of course accept that. Or if a doctor has cancelled his OPD last minute due to an emergency, has the patient been informed? Or if the doctor has been delayed, is the patient or the family been informed that their appointment is getting late? It can't be structured, it can't be 100%, we'll have to live with that. But yes, the organization has started making the effort to be more sensitive to patients' waiting times and starting to communicate with them. That should satisfy us and say, yes, the organization is very sensitive and patient-centric in their approach. AAC 12I, the organization has a mechanism in place to monitor whether clinical intervention has taken place in response to a critical value alert. So this is a new objective element, where in the other standard we are saying that they must be, the critical values must be known and reported. Now here this is closing the loop. That means if you have reported the critical value, has any medical action taken place at the bedside of the patient in response to a critical value alert? So this is a very good standard. So as assessors, we will go and check at the lab end their critical value timings or which report has taken, take one sample, and then go to the patient regarding that on whom the critical value was relevant, go to the bedside records of the patient and see what happened. Did the patient, did the staff receive and record the critical value on time? Did she or he take immediate action like informing the doctor on duty or the consultant in charge? And what treatment was initiated to respond and correct that critical problem of the patient? So we will check both ends now to make sure that this objective element has also been met. In case of OPD, efforts will be taken to alert the patient or family about the critical values. We know it is very difficult. We are not expected to take responsibility, but I think under NABL, there is a requirement to alert the patient and family about the critical values. So if you are able to send an SMS to the treating doctor or to the patient, or call them and say that, this report has come out very high, you are advised to go to the nearest emergency, the hospital would have met its responsibility. The second last standard is about discharge, the discharge process. We are all very familiar with this. The AAC 13D is on the discharge summary, where we say a discharge summary is given to all patients. Here they are just reinforcing that a discharge summary has to be given in a proper format even to patients who are refusing treatment or leaving the organization. So we must respect and give all patients, LAMA cases, DAMA cases, a discharge summary. Here the new objective element around this standard is that we have to define the time taken for discharge and also monitor it. So the hospital will define the time it takes for a discharge, monitor the delay, and start taking initiatives to try and reduce the discharge delays and complete the discharge in a timely manner. But if you find that the discharge is not in a timely manner, you should not say the organization is not discharging the patients in a time-bound manner and give them one big NC. That's not the correct way to go about it. I would say that you go and check the hospital has started monitoring the time of discharge. They are making an attempt to say that we will try and discharge our patients, say, within 4 hours of the doctor's orders, and then they are monitoring. If they say 40% of our patients are meeting the time requirement of within 4 hours, and the rest 60% patients are being discharged in 8 hours, we should ask them, what are you planning to do to reduce this? We all know 100% of hospitals in the world are not able to meet the standards laid down for discharge time. So as assessors, we have to be very practical. If they are monitoring, they are evaluating, and they started taking steps to try and reduce the discharge time, we should be satisfied with that. Okay? Don't be very bookish in our assessments. Organization defined, yes, but on the other hand, if the hospital is not even monitoring and they are just giving lip service to us and they are not bothered, they're trying to cover up and show in the NC, then you have every right to say that the hospital has not defined and is not monitoring the same. Organization defines the content of the discharge summary. Here, they are asking that in the interpretation, the patient and the family should acknowledge the receipt of the discharge summary. So we must get a signature of the patient or the family at the time of handing over the discharge summary, and also making sure that they have understood what is there. So this 14E is about that whatever the patient needs to know should be given in an understandable manner, right? In a language and a manner that they understand. Now, for instance, we all know that we write discharge summaries in English, I think in near 100% of cases. Maybe in the odd case we are giving discharge summaries in Hindi, or in other local language, I'm not aware of that. But we also know that all our patients are not able to read in English. So the question that comes to us is, to interpret the standard, are we expected to ask the HCOs to start writing the discharge summary in the local term? No, that would not be very practical. It would be ideal, but it would not be very practical for a hospital. So at least they are verbally explaining to the patient on the medication and the advice, so that they understand, like you do in a consent, get their signature, and avoid jargon terms which they will not be able to interpret. Now they are not familiar with QID or BD. So at least in that they should be clear. Either you use a symbolic language or you write it in full without abbreviations, so that even if a patient doesn't understand, he can ask somebody to explain it to them and it is clear. So again, don't look at perfection and idealistic, but yes, there should be the approach towards making sure The hospital is not just giving a summary, but attempting to ensure that the patient is understanding what they are explaining and giving instructions about. That's the intent of the objective element. Okay. So with that, I come to an end of the 4th edition changes, the new requirements. We will now, we are, I think, well on time, and we have 100% attendees over here. Thank you for your patience. I will now invite Dr. Kalra also onto the screen and open this session for questions for the next few minutes.
Thanks a lot, ma'am. Thanks a lot, ma'am, for that enlightening session. So now we'll take up the question answer session. So there are two options where you can raise your question. One is that you can raise your hands and then we'll unmute you and you can ask your question in person. Second option is you can write it on the chat and then we'll read it and then the question can be answered. So, ma'am, there are few questions which have already in place. So the first question is from Dr. Sajan Nair. So the question is that how many years of experience is required for specialty nurses, like some nurse working in neuro ICU?
There is, you can have various answers for this. I think 1 year of experience should be good to achieve a moderate amount of competence for taking care of patients in that ICU. Even 6 months, if somebody's got prior experience, and 6 months to 1 year.
Okay. So the next question is from Harshad Joshi, and he want to ask, just like if there is a partial service available in a hospital, like some services in neurology or neurosurgery, so can it be considered for display as neurology facility available in HC or not?
Or a scope to be included, whether it is a neurology, cardiology, or any other specialty, there has to be a provision. They should, for OPD consultation, there should be a schedule available. If so and so doctor is coming to the hospital for OPD consultants, they are able to admit patients, and there should be evidence. Then for even admissions, there should be emergency services also available for particular specialty. And then discharge and follow how after, say, is a neurosurgical patient. Surgeon comes, operates and goes away. After that surgery, who is taking care of that patient? That should be evident. The record should be there to see all this. Besides this, there should be a adequate equipment of that specialty available. So if all these things are available, that should be considered for scope of services, say neurosurgery, neurology or cardiology. There are examples. There are certain hospitals, they say we have cardiology should in scope. There is no cardiac cath lab. In such cases, they should clearly write in the scope OPD only. Cardiology on the bracket only OPD services. They cannot write full-fledged cardiology, interventional cardiology in the absence of a cath lab. I think this rule applies for all the specialties. Again, to repeat, it's not required. There should be every week, all days, there should be a specialist coming. There should be a fixed schedule. It may be in-house or maybe a visiting consultant, but there should be a regular schedule. Should be there. He's coming once a week or once so and so date. Then evidence for admissions, then emergency admissions, surgeries, who's looking after the patient, how taken care of, and then discharge. And sufficient adequate equipment for the concerned specialty. Only that should be included under the scope. In that way, assessment should be done.
May I request the assessors that if you feel in the next 6 months, because you are going to face some new standards and new challenges, both at the HCO level and the assessor level, if you are in a 3-day assessment or a 2-day assessment and you're having a doubt, before finally writing the NC, please write to NABH and say, sir, I'm difficulty. please advise me, does this qualify to be an NC or not? We will be happy to mentor you on a confidential level and guide you if you are ever stuck. Okay? And this just doesn't apply to the new NCs, this new standards. This can apply to any. Please feel free to collaborate. We are all in a journey of continuous learning, and none of us knows everything, A to Z.
Thanks a lot, ma'am. Thanks a lot, sir. I think we are getting a huge pile of questions here. So, in case, I just want to communicate to all that in case if we are not able to answer all the queries in stipulated time frame, so we'll be writing them back. So the next question I'm combining from two people, that's Antonia P and Dr. Naveen Chugh. So the question is just like for BLS and ACLS training, who is qualified to do so and what type of documentation is required?
Obviously, the ideal standard would be AHA, but NABH says please be flexible. If a hospital has organized its own training program, its own certification program, or say for instance, IAP is running a program for pediatrics in PALS and NALS, or say CAHO is organizing, or a local
or even
society is organizing.
Even anesthetist available in the hospital, if he is providing that training, that should be acceptable.
And you should, if you have any doubts, you can check the competence through a mock when you do that.
It should be known under which standards and guidelines the training is being imparted by a competent person.
Yeah, and if you find, you can do a mock and say, show me the steps of CPR, or show me the steps of how you will, what are the ACLS or ALS protocols that you have. If you find that people don't know, you can put that as a observation.
Okay, thank you. So now we will be unmuting Meenu Chopra. Next question is from Meenu Chopra. So Meenu, we have unmuted you, so you can raise your question.
Yes, Meenu.
So in the meantime, while she is getting connected, again I'm combining 2-3 questions together. So the question is on handover. So where it should be documented? Do it need to be documented in the patient record, or there need to be a separate register for handing over? So
you can use both approaches. The doctor-to-doctor handover can be because it's very difficult to expect a doctor covering 40 to 50 patients to hand over it in the patient record and then go off duty. You can have a register where in the ward where there's an over register where the doctor is highlighting some patients, we need not even be 40, 50 patients. Some patients who require that specific instructions at the time of handover are written. But for a nurse handover, it should be part of the patient record.
So just
in the nursing record. For all patients.
Yeah, just a comment from Farhan Sheikh. So he is commenting that I feel that it should be structure handover should be in medical record. In case of medical legal situation, it can be helpful. But colleagues in my hospital are asking whether maintaining a round register will suffice it or not.
It will be very practical from a doctor perspective, but transfer notes and nurse-to-nurse handover can be part of the medical record.
That register which already mentioned is also a part of sort of a medical record that should be preserved.
Okay.
Yes.
So
the policy of the hospital. The hospital makes a policy where the recordings are being done on particular aspects.
Okay.
But from an assessment perspective, if they are maintaining a register separately, we should at least in the beginning accept it.
So now we'll try again for Charul Purani. So we'll unmute Charul Purani.
And what is the ideal time for corporate patients? Ideal time for discharge summary to be handed to the corporate patients?
Corporate patients meaning what? Empanel patients?
Yes, ma'am.
PPA patients?
Yes, ma'am.
We know practically it takes 6 to 8 hours. That's the reality today. But that's not the ideal way. And sometimes the hospital is dependent on a TPA which is sitting outside the hospital premises, and it's out of their control to get this. So practically we know it takes 6 to 8 hours. It's only the cash patients who are able to get discharged early. Hospitals, some hospitals I know have made some success in this and brought it down to 5 hours or 6 hours. So you should focus more on those situations where things are under the control of the hospital.
But hospitals should make an effort, reduce the time to 4 to 5 hours maximum.
Okay.
Thank you, ma'am.
So the next question is from Rajesh Damodran. So the question is, will the slides be available to us? So
you can answer that.
Yes.
Yes.
So asking this query, we are recording.
Yeah, we will make available these slides on the website, and even questions which are being asked, the answers will again, whatever we are given, again we will have a consultation with the group and we'll upload in the assessor forum.
FAQs.
There we can even upload these all answers and questions.
The next question is from Dr. Puneet Agarwal, that who can do nutritional screening?
Who can do?
Who can do nutritional screening?
Nutritional screening.
Screening.
Obviously, it has to be.
Even it can be even dietitian.
If you are restricting it to
or
BMI.
even a physician. They are all capable of doing nutritional screening. But for a particular disease problem, particular special type of a diet, it has to be a dietitian or a physician.
Or a nurse also.
Or a nurse, if trained. For at least screening, nurses we can accept that if they are trained for nutritional screening.
Okay. So next we are inviting question from Rajiv Kumar. Rajiv Kumar, you can ask your question. Rajiv Kumar, can you hear us?
Yes.
Rajiv.
I think he's not.
Yes, Dr. Rajiv.
So next question will take from Sundari Singh.
Yes, sir.
Hello, Sundari. How are you?
Fine, ma'am. Good evening, sir. My question is, can Code Blue team double as rapid response team? Because
Yes.
our hospital.
Yes.
Thank you.
If it's a small hospital.
Yeah.
If it is
Yes,
a big
ma'am.
hospital, Sundari, then
No,
sometimes you may have a lot of RRT calls. Suppose it's 600, 700 bedded hospital. Then it is better to have a RRT team on the floor or from an ICU, close by,
Yeah.
so that they can reach fast and more often.
Yes,
Okay,
ma'am.
thank you, ma'am. So next question is from Hemant Bhatnagar. So the question is, what should the HCO do in case they are outsourced a particular service in terms of display on scope of services?
This question has come in earlier also. What he's saying is that there are two ways of outsourcing. Outsourcing in situ. That means you have outsourced your laboratory to, say, a third party, but that third party has put up a lab in your premises, or a pharmacy. Then it is part of your scope. It is included in your scope. But suppose you don't have the service in your premises, then you can't say, na?
Nearby we accept.
Very close
Very close by, we accept. If need be, even that close outside the laboratory can be visited. There has to be some kind of a quality mechanism for outsourced services. If it's not within the hospital, then preferably it should be a sort of a NABH minimum. But there has to be nearby hospital, not very far away from.
Within the closed premises, like as good as inside the hospital.
Yeah.
Then you can include it in your scope.
So just pertaining to this scope of service, the next question is from Priya John. So the question is that is there any specific size pertaining to display or a board of for scope of service, and then how should referral service issue be shown or displayed to patients if some services are being outsourced, or how they can be displayed?
They'll have to use their own means to just write referral service to so and so for this, or just write referral for, say, radiation therapy available, simply put like that.
Okay. So the next question is from Fernandez. Hello. Sir, can you hear us?
Speak a little louder, please.
Hello. So we'll ask next question from Ashok Khandelwal.
Yeah. Hi, Ashok. Shoot.
No. So we again got a big pile of question. I think the time will be too much.
I think
for all the
not more questions. They can post us. We will reply on the website.
Yeah, keep posting questions on email to Dr. Kalra or to Prashant, who has sent you the webinar invitation, and you will get a revert from NABH promptly.
And for those questions,
in fact, you should not wait for a webinar. You should keep sending questions in. Any doubts you have.
And the question which we have already received, we will also answer for that as well.
Yeah, we'll put the answers.
Yes.
Okay, with this, I think thanks a lot, ma'am. Thanks a lot, sir, for this session. And hopefully it have been useful for all the assessors who have attended this session. Many of our assessors were not able to attend this session because of limitation of the seats available.
Yeah.
So we'll be repeating this session again. So those who are not able to participate now, they can come in the next session. So thanks a lot. With this, we'll close this session.
Amit, I will just ask Dr. Kalra to sum up.
Thank you very much, all the participants. I think it was a very good beginning. And I will wait for the feedbacks on the session from you all. And some of the feedback already we have received, we have seen. But how further we can improve. And definitely please send feedbacks. And once again, I thank you all for active participations. Thank you.
Thank you. Bye-bye.